What if I told you that the very pill you've taken for decades to protect yourself might actually be the exact thing causing your absolute worst perimenopause symptoms?
Yeah, it's a terrifying thought, right?
Totally. Welcome to the Deep Dive. Today we are taking on a massive mission for you, the listener. We are deciphering this highly requested, heavily misunderstood medical puzzle.
And it really is a puzzle for so many people.
It is. The question is, how do I safely transition from the combined oral contraceptive pill to hormone replacement therapy, HRT, without experiencing just this massive crashing surge in symptoms?
Right, because it's a transition where the old medical advice often actively contradicts the modern biological evidence we have today.
Exactly.
So people are just left navigating this giant blind spot in women's healthcare, usually with, totally unnecessary discomfort.
And to clear this up, we brought in a serious stack of material. We're looking at the latest clinical guidelines from the British Menopause Society, the Faculty of Sexual and Reproductive Health Care, current NHS treatment pathways, and even specialized clinic protocols.
Which I've got all my notes pulled from right here because we want to be incredibly precise.
Yes, our goal is to extract the exact clinical playbook. We are going to map out when to switch, the pharmacology behind why these hormones are fundamentally different, and basically give you the step-by-step strategies to make this transition so seamless that your body barely even notices the handover.
The data here is actually incredibly clear once we strip away all those outdated practices.
Right.
But before we get into the mechanics of the handover itself, we really have to establish the baseline of what these two treatments are actually doing in the body.
Okay, let's unpack this, because this is where I think a lot of people, including myself initially, get really tripped up.
Oh, absolutely. It's confusing.
Wait, I'm confused. If both the combined contraceptive pill and HRT contain estrogen, why does one act as a highly effective contraceptive and the other just doesn't? I mean, isn't estrogen just estrogen?
It's a great question, but, well, no. It really comes down to dosage thresholds and molecular structure. The combined oral contraceptive pill utilizes synthetic hormones. So a very common one is ethanoestradiol, and the pharmacological goal of that pill is total suppression.
Total suppression.
Right. It delivers a high enough dose of synthetic estrogen to essentially hijack the brain-ovary communication loop. It just floods the system, tricking your brain into thinking you are already pregnant.
Oh, wow.
Yeah, which completely shuts down ovulation and flattens out your natural hormone fluctuations.
So if I'm understanding this, the pill is essentially a sledgehammer.
Sledgehammer, exactly.
It is a blunt, powerful instrument designed to just shut the whole factory down, whereas HRT is it's more like a thermostat.
That is a perfect analogy.
Right. It uses a fraction of the hormone dose, typically bioidentical estradiol, and its only job is to just turn the heat up a little bit to keep the house comfortable as your natural levels decline. It supplements. It does not suppress.
Exactly. And that distinction is the biological mechanism behind why age 50 is the critical pivot point in all of these clinical guidelines.
Right, the magical age 50.
Yeah. The UK medical eligibility criteria, the UK MEC, they state that combined hormonal contraceptives are relatively contraindicated after age 50.
Which means the risk outweighs the benefit. But let's dig into the why there. Why does the sledgehammer suddenly become so dangerous at 50?
It has to do with how the liver processes oral synthetic hormones. It's a process called first-pass metabolism.
Okay, first-pass metabolism.
Right. When you swallow a combined birth control pill, it dissolves in your stomach and is carried directly to the liver via the portal vein before it reaches the rest of your body.
So the liver gets the absolute first crack at it.
It does. And the liver's reaction to a really high dearth of synthetic ethanoestradiol is to ramp up production of certain proteins. Crucially, it increases the synthesis of clotting factors.
Wow, like prothrombin and things like that.
Exactly, prothrombin and fibrinogen. Now, when you are in your 20s or 30s, your cardiovascular system can generally handle that slightly thicker, more clot-prone blood.
Because your vessels are younger and more flexible.
Right. But as you cross the threshold of 50, your baseline arterial stiffness and your cardiovascular risks are naturally increasing anyway.
So you're adding fuel to the fire.
You really are. Forcing your liver to pump out extra clotting factors at that age pushes your risk for deep vein thrombosis, pulmonary embolisms, and strokes into a clinically unacceptable zone.
That is terrifying. But meanwhile, modern HRT bypasses that entire metabolic trap, right?
Yes, completely.
Transdermal HRT, so we're talking the patches, the gels, the sprays. Delivers bioidentical estradiol directly through the skin into the bloodstream. It just skips the gastrointestinal tract, and it skips that first-pass metabolism in the liver entirely.
The liver is never provoked into producing those dangerous clotting factors.
Wow.
So the transdermal route provides all the symptom relief of estrogen without that heavy cardiovascular tax.
Which brings us to a massive, flashing neon warning sign in the sources. The absolute golden rule of this whole transition.
Your golden rule.
You cannot take the combined birth control pill and HRT at the exact same time.
No, absolutely not. The pharmacology simply doesn't allow for it. The combined pill is already, saturating your hormone receptors to achieve that total suppression.
Right.
Layering HRT on top of that synthetic sledgehammer pushes your total estrogen load into a hyperestrogenic state. You'd be aggressively multiplying those exact clotting and stroke risks we just mapped out. You have to pick one lane.
You can't double stack them.
Well,
So since we can't double stack, we have to cross a bridge from one to the other.
mm-hmm.
And historically, the medical advice on how to cross that bridge has been nothing short of brutal.
Brutal is the right word.
The sources show that for years, women were instructed to stop taking the high-dose pill cold turkey, endure a completely hormone-free gap for 6 weeks, and then go take a blood test.
Ah, the infamous FSH test. What's fascinating here is how clinicians used to rely on testing follicle-stimulating hormone FSH to basically prove a patient had officially crossed into menopause before prescribing HRT.
To prove it, like you have to earn it.
Yeah, exactly. But modern clinical guidelines from the Faculty of Sexual and Reproductive Healthcare now explicitly advise against this for anyone using hormonal contraception during perimenopause.
Let's break down the biology of why that blood test is so useless. It has to do with that brain-ovary feedback loop we mentioned earlier, right?
Right. So the pituitary gland in your brain is constantly monitoring the estrogen levels in your blood. When it senses estrogen dropping, it releases follicle-stimulating hormone.
Which is basically a chemical text message screaming at your ovaries to wake up and produce an egg.
That's a great way to put it. Yes, it's screaming. But during perimenopause, your ovaries are running out of viable follicles, so they don't respond reliably.
So the brain screams louder, and the FSH levels just spike.
Exactly. But then randomly, an ovary might, sputter to life and produce a sudden burst of estrogen. The brain senses it, stops screaming, and FSH plummets right back to normal.
That's a roller coaster.
A total roller coaster. That chaotic signaling environment means FSH levels fluctuate wildly on a day-to-day, sometimes even hour-to-hour basis.
So pulling a blood test just gives you a snapshot of a single second of a highly volatile process.
Precisely.
It might be sky high on a Tuesday, prompting a doctor to say, oh, you're in menopause, and then completely normal on a Thursday. It is a terrible metric for deciding if someone deserves symptom relief.
It really is. The diagnostic criteria has shifted entirely now. We treat based on clinical symptoms, not arbitrary blood markers.
And the really tragic irony is, by forcing patients to endure that 6-week gap just to take a totally useless test, the medical establishment was inducing the exact symptoms the patient was trying to avoid.
Right. We call it the symptom surge. And the mechanism behind it is, well, it's severe.
Tell me about it.
Remember, your body has spent years, maybe decades, adapting to the artificially high synthetic estrogen of the combined pill. Your cellular receptors are downregulated. They're used to a flood of hormones.
So stopping cold turkey isn't just going back to baseline. It's like driving a car at 100 miles an hour and throwing it into reverse instead of easing onto the brakes.
The physiological whiplash is profound. The estrogen receptors in your brain, your blood vessels, and your nervous system are suddenly completely starved.
Wow.
And that acute receptor starvation is what triggers the violent vasomotor symptoms. The brain literally loses its thermoregulatory control.
Which means severe hot flashes and night sweats.
Exactly. And the sudden deprivation also crashes your serotonin and dopamine production, which leads to intense mood swings and brain fog. It is a state of acute biological withdrawal.
I mean, your treatment should evolve with you, not punish you. You shouldn't have to suffer through an induced withdrawal just to prove to a doctor that you need a blanket because you're freezing.
Absolutely. The clinical consensus is now crystal clear on this. Inducing a hormone crash for diagnostic box checking is an obsolete and, frankly, harmful practice.
Okay, so throw the gap out the window. What is the actual clinically approved playbook? How do we seamlessly transition the listener from the pill to HRT without crashing the car?
The sources outline what they call a seamless switch protocol. You finish your current pack of the combined pill.
Finish the pack.
Yes. You do not stop mid-cycle because that would disrupt your uterine lining. You take the final active pill, And then the very next day, instead of starting a new pack, you apply your new transdermal HRT patch or gel.
It's like a pharmacological baton pass.
That is exactly what it is.
Yeah.
While the synthetic ethanyl estradiol is clearing out of your system because it has a specific half-life, the bioidentical transdermal estradiol is simultaneously absorbing through your skin and entering the bloodstream.
So the estrogen receptors are never left starved.
Exactly. You completely avoid the crash.
But we can't just give you estrogen. If you have a uterus, unopposed estrogen is dangerous.
Very dangerous, yeah.
Because it stimulates the endometrial lining to grow and thicken, which is a primary driver for endometrial hyperplasia and eventually uterine cancer. We need to protect her.
Right, which brings us to the second half of that HRT regimen, the progestogen. The guidelines typically recommend starting oral micronized progesterone, usually taken nightly. Progesterone acts as the counterbalance. It stabilizes and thins the uterine lining, keeping it completely safe from the estrogen's growth signals.
Though, we should set some expectations here. Even with the seamless switch, you are moving from a very high-dose synthetic suppression to a lower-dose bioidentical supplementation.
True.
The brain and the body need time to upregulate those receptors and get used to the new thermostat setting. The guidelines note it takes roughly 6 to 12 weeks for the new HRT regimen to fully stabilize.
Right, so you might see some breakthrough bleeding or minor temperature fluctuations during that calibration phase.
But that is normal physiological adaptation, right? Not a failure of the medication.
Exactly, it's totally normal. But, and this is a big but, the sources highlight a brand new, highly critical clinical caveat that disrupts this entire seamless switch.
Oh, the GLP-1 factor.
Yes. It involves the newest class of weight loss medications, the GLP-1 receptor agonists, like Wegovy or Mounjaro.
This is fascinating to me. If you are taking a GLP-1 medication, it fundamentally alters your gastrointestinal mechanics, which directly impacts your HRT. How does that work?
Well, GLP-1 medications are incretin mimetics. One of their primary mechanisms of action is to significantly delay gastric emptying.
Gastric emptying meaning how fast your stomach digests.
Exactly. They physically slow down how fast your stomach digests contents and empties them into the small intestine. And the small intestine is where oral medications are actually absorbed into your bloodstream.
Oh, wow. Let's map out what happens when you swallow that oral micronized progesterone pill at night while on a GLP-1.
So normally, the capsule breaks down, the progesterone hits the small intestine, and you get a reliable peak serum concentration in your blood.
Right.
But with delayed gastric emptying, that capsule just sits trapped in the highly acidic environment of the stomach for hours. The active hormone degrades before it ever reaches the absorption site. The pharmacokinetic curve is completely blunted.
Which means the progesterone is never making it to your bloodstream in high enough concentrations to travel to your uterus and protect the lining from the estrogen patch. You are inadvertently leaving yourself exposed to endometrial thickening.
And the British Menopause Society has flagged this as a serious emergent risk. The temporary clinical fix, especially when a patient is first initiating a GLP-1 or titrating up to a higher dose, is to artificially overpower that delayed digestion.
Overpower it how?
A doctor might double the oral progesterone dose for several weeks just to ensure enough active ingredient actually survives the stomach to protect the womb.
Wow, just brute force it.
Yeah.
But the more elegant long-term fix is to pull the digestive system out of the equation entirely, right? You change the route of administration.
Exactly.
And that naturally leads us to the final and arguably most important piece of this whole puzzle. By lowering your estrogen dose to protect your liver, we stripped away the one thing the pill was actually designed to do.
We remove the contraceptive shield?
Exactly. HRT is not birth control. The thermostat is high enough to stop your hot flashes, but it is nowhere near the threshold required to suppress ovulation.
It really isn't. And the fertility window post-50 is much wider than our cultural narratives suggest.
Seriously.
The biological reality is that spontaneous ovulation can and does occur even as periods become highly irregular.
So what's the actual rule there?
The clinical rule is that you must assume fertility remains for 1 full year after your last spontaneous menstrual period if you are over 50, and for 2 full years if you are under 50.
Okay, let that sit for a second.
Yeah.
You are not officially clinically cleared from unintended pregnancy risks until you hit age 55.
Age 55, yes.
Now, you drop the sledgehammer, you do the seamless switch to the patch, you feel fantastic, but you are totally unprotected. We need a solution that multitasks.
We need symptom control, cardiovascular safety, endometrial protection from the estrogen, and highly effective contraception, all operating simultaneously.
That's a tall order. But the sources point to one specific medical device as the absolute undisputed heavyweight champion of this transition, the 52 milligram levonorgestrel intrauterine device.
Commonly known as the Mirena coil.
Yes. If we connect this to the bigger picture,
Mm-hmm.
why is this such a game changer?
Well, the LNG IUD is a localized delivery system. Instead of swallowing a pill that has to, circulate through your entire body, the IUD is placed directly inside the uterine cavity.
Right at the source.
Exactly. It secretes a steady microdose of a progestogen called levonorgestrel directly into the endometrial tissue.
That is incredibly efficient. You're essentially using the IUD to solve a problem the GLP-1 medications just created.
Yes. It completely bypasses the gastrointestinal tract and the liver entirely. The local concentration of progestogen causes profound suppression of endometrial proliferation.
It thins the lining perfectly.
It thins it so effectively that it provides 5 solid years of guaranteed protection against the estrogen in your HRT patch.
And because it's localized, the systemic absorption, like the amount of hormone that actually makes it into your general bloodstream, is negligible compared to an oral pill.
Right. And while it's protecting the womb, it is simultaneously acting as a top-tier contraceptive device. It locks down that pregnancy risk all the way up to age 55.
It's amazing. If you have the Mirena coil fitted before you turn 50, the transition protocol becomes almost laughably simple.
Oh, it's so easy.
You just finish your combined birth control pill, you stick on an estrogen patch the next day, the IUD handles the contraception, the IUD handles the wound protection. No symptom gap, no stomach absorption issues, no massive systemic hormone load.
It is the ultimate bridge. And, for those who cannot or just prefer not to use an IUD, the alternative bridge is the progestogen-only pill, the mini pill.
Right, because that doesn't have the estrogen risk.
Exactly. It lacks the dangerous synthetic estrogens of the combined pill, so it's totally safe after 50, and it provides the necessary contraceptive cover while you use your HRT patch.
So what does this all mean for you, the listener? Let's recap the mission parameters for a safe, symptom-free transition. Step 1. You refuse the gap. You do not subject your brain and body to receptor starvation and the subsequent crash just to take an outdated FSH blood test.
Please don't do it.
Step 2. You execute the seamless switch. You finish the pill pack and start a transdermal estradiol patch or gel the very next day, bypassing the liver and protecting your cardiovascular system.
Seamless is the key.
Step 3. You ensure your uterine lining is protected with a progestogen, adjusting the delivery method if you are on a GLP-1 medication.
Yeah.
And Step 4. You build a contraceptive bridge, like the Mirena IUD or the mini pill, to cover that lingering fertility window until age 55.
It is entirely possible to navigate this without suffering. It just requires utilizing the modern pharmacology correctly.
Transitioning off the birth control pill isn't a failure, and it isn't waving a white flag to aging. It is just a highly calculated upgrade to your biological toolkit.
Before you go, consider this. We have spent billions of dollars and decades of research perfecting the science of shutting a woman's reproductive system down. We engineered the combined pill to be a flawless mechanism of suppression.
We really did.
Yet we have spent only a fraction of that time and capital studying how to support that same system as it naturally ages. As you navigate this transition, armed with the actual mechanisms of how these drugs work, ask yourself, are you getting the standard of precision care you deserve, or just the standard of care the medical establishment settled for?